I want to go back to something before we leave this whole topic that I think is important because my residents ask about this all the time. And I can now tell them that I've spoken to the experts about this, which is I've got somebody in the ICU, not particularly sick from a diarrheal perspective. They're in the ICU for some other reason. But they see a white count of 23,000, and maybe there's been a little loose stool, but they're also on tube feeds and or something else. They go, what's the harm? We'll just start a little Vanco. And you're telling me, get the test, empiric therapy for C. diff no longer makes the guidelines.
Yeah, I think that's generally true. The increase in empiric therapy of C. diff or suspected C. diff really resulted from the emergence of this NAP1 strain, because in Pittsburgh and in Montreal, there were huge outbreaks. In Pittsburgh, for example, they did 16 colectomies in the first year of their outbreak.
16?
16 colectomies. I had, I think, seen one colectomy in 25 years of experience with C. diff at that time.
Right.
But as a result of that, because of this was such a fulminant disease process in some of these patients, empiric therapy became almost standard. In Montreal, if you had diarrhea, one stool, vancomycin was started and the stool specimen was sent off and you were isolated immediately. And so this kind of empiric management became very prevalent because of the severity of the disease. We are not seeing as much of these really fulminant severe cases as in the past, and I think with the new guideline, we're going to try to back off a little bit on the urgency to start treatment. And basically, and the other thing that's happened is we have rapid diagnostics that give you same-day answers. And if you can get this answer in the same day, this will avoid unnecessary isolation, also avoid unnecessary treatment.
I was going to go there because I think that's critical. It used to be we'd have to wait a while. Now we can get an answer back fairly quickly.
Yep.
If you can get stool.
If you can get stool.
So if your ICU patient on the ventilator, bedbound, has abdominal distension and an ileus and a white count of 25, 30,000, you may have to wait a while to get a stool sample. That person might still benefit from empiric therapy.
But again, it's as you implied, it's always dependent on the clinical presentation, right? Sick people need more aggressive therapy sooner. And I couched it actually directly against that example. Somebody who's not clinically toxic and maybe doesn't have that much stool, but has a white count, you're worried about it, test first before you go ahead and start empiric therapy. Is that fair? Guidelines work for that?
Yep. And in our pathway, as I mentioned, the only other situation in which we recommend empiric therapy is when you know you have very high certainty that the patient has C. diff, even if the patient is not terribly sick. As you mentioned, when someone in the hospital has all of a sudden explosive unexplained diarrhea, didn't have any trigger for that, and a bump in their white cell count.
Right.
And very often, you asked about testing, very often we'll order a KUB, a belly, just a plain x-ray that shows dilatation of the colon. In those patients, we're okay with starting empiric therapy. It's a small fraction of the patients.
Right. Sick people, treat. Everybody else, test. And then when you treat intelligently. How about that for a summation for this whole segment? And the devil is in the details now, isn't it?